America is aging, and so is its opioid epidemic. Nearly 20,000 people over the age of 55 died of an opioid overdose in 2023. As of right now, some 1 million seniors are living with opioid addiction. And they're often grappling with problems like arthritis, diabetes, heart failure, plus housing, hunger, and loneliness. Add all that up, and getting many of these patients the help that they need is hard.
You fall in between the cracks. I mean, you just fall. It's just nothing there to help you.
Today, we go inside one clinic, catching some of those people falling through the cracks, and explore what it would take to make care better for more Americans aging with addiction. From the studio at the Leonard Davis Institute at the University of Pennsylvania, I'm Dan Gorenstein. This is Tradeoffs. "67-year-old Renee Gray is ready. For more than 2 years, she's been wanting to do something about her hip.
I can't walk a whole block. I had to keep stopping and sit down because that's how bad it hurt.
When we met in mid-January, Renee finally got relief in sight, a hip replacement scheduled for February. And to prepare for it, she's come to what may seem like an unusual place.
These are the papers, Dr. Burnett, for my operation.
Okay, cool. So
A methadone clinic for people with opioid addiction in Baltimore, Maryland.
have you talked with the surgeon?
No.
It's called Reach Health Services.
Okay. They may tell you that they want you to stop taking your methadone beforehand.
I know, they did.
Don't do that.
The kind of place that knows Renee can get her hip replaced without stopping medication that's kept her off heroin these last 14 months. The day that I was there, Reach's executive director, Vickie Walters, told me that she thinks the clinic plays this dual role for their patients. Part advocate, part air traffic controller.
In a sense, we call what we do primary care light. We see ourselves, really, our role as getting people connected to the care that's already in the community and helping to facilitate that, helping them to follow through, and to really go the extra mile.
Reach is less primary care clinic where you get checkups, more a place that's equally on top of your addiction, your blood pressure, your housing. A clinic that quarterbacks all of a person's care. Malik Burnett, who directs medical care at Reach, says this is critical for their more than 300 highest need patients.
It's not easy to navigate the health system for anybody, right?
But Malik says U.S. healthcare is particularly treacherous for older Americans dealing with addiction, especially if they're low income. Many of Malik's patients getting this extra help, including Renee, check all three boxes. It's a combination that Malik believes puts people in unique danger.
If they fail to engage in the health system as they get older and they have more chronic conditions, they're going to die. You have unmanaged substance use disorder and multiple chronic medical conditions, none of which are getting managed. You're just going to die from something.
Accurate numbers on opioid addiction, a condition often shrouded in shame and secrecy, are hard to come by. But the best numbers that we do have point to a growing problem that America's healthcare system is struggling to meet. Between 2013 and 2018, the share of seniors on Medicare with opioid addiction tripled. Much of this group suffers from at least half a dozen chronic physical conditions. Yet all-in-one support, like the kind Reach provides, coordinating a person's mental, medical, and social needs, is rare.
Comprehensive care for these incredibly complex patients is definitely a needle in the haystack kind of thing. It's really very uncommon.
Lisa Clemans-Cope is a senior researcher at the Urban Institute, a Washington, D.C. think tank. Lisa says there are fewer than 10 states where methadone clinics get paid to do this extra work, and even in those states, many choose not to. But failing to address the full suite of these folks' needs can come at a big cost. One study found that the federal government spends north of $10 billion a year for people on Medicare with unmanaged opioid addiction. To be clear, providing more comprehensive care for this population costs money too, and it's pretty hard to do. But Renee Gray will be the first to tell you the results, they can be extraordinary.
Do I think I'd be alive if I didn't come here? No.
Renee started using heroin in the 1990s. It took her about 30 years to stop. The turning point came in the fall of 2023. Renee was living with her daughter, and she'd been using heroin to numb this excruciating pain in her hip. But the drug had stopped helping. That night, she was high, and she was in agony.
Crying and twisting and turning in the floor. When I think about it, it makes me feel bad. But I was really crying because I was in so much pain. And then using them drugs too it seemed like the drug was making it worse.
Renee's daughter, Latia, was terrified seeing her on the floor like that. Instinctively, she reached for her phone.
My daughter recorded me just so she could show me how I was acting.
Latia played it back for her mom the next day.
And when she showed me that, I felt this small. And I couldn't lie. I said, yeah, that's me. You know, and I just like I told her, I said, I don't care who getting high, who doing what. Renee ain't gonna do it.
72 hours later, Renee walked through the front doors of Reach. Like a lot of people who have used street drugs on and off for decades, she was in pretty rough shape.
I was really doing bad when I first came in here. I wasn't going to my primary care doctor or nothing, none of that.
Teeth decaying, vision shot, sky-high blood pressure, that debilitating pain in her hip. Renee will tell you, for decades, her health was an afterthought. Addiction was a huge part of that, but shame was a part of it too. Past visits to her primary care doctor had left Renee feeling low.
She would stare at me like, you know, why you use drugs, or, you know, like I was dirt or something, you know, and just made me feel bad. I know I look bad, but you ain't gotta, you know, talk to me like that.
Research suggests Renee is not alone. One study asked several hundred doctors and dentists for their honest opinions about the types of patients they'd prefer to see. A full 1/3 admitted they would rather avoid patients with opioid use disorder, a far more negative response than any other patient group, including people with alcohol addiction, HIV, or diabetes. Reach estimates that about 95% of their highest need patients have no connection to primary care when they first show up. So the clinic makes rebuilding people's bridges to the rest of the healthcare system a central part of its work.
That's what I'm here for, to make them feel comfortable and more relaxed about taking care of their health problem.
Phyllis Lindsay works as a peer specialist, a kind of coach for Reach patients, including Renee. She's part of a super team to address people's recovery and their physical, mental, emotional, even social needs. Together, this team lines up appointments, referrals, rides to the doctor. As important as navigating the healthcare system may be, Phyllis says most folks at Reach need that and something that too often is in short supply.
They need attention. They need somebody to listen to them. They need somebody to really hear them and internalize what they're trying to say to them.
That need, that's why Phyllis, nearly 20 years into her own recovery journey, is here, and why Reach has a mental health therapist too. Sometimes the clinic even fills the role that a close friend or family member might. Someone who's got you will go to that doctor's appointment that you're dreading. The sad reality, says Phyllis, is that many of her clients don't have a person like that in their lives.
When you've been in addiction for a long time, you get cut off from reality. People disown you, stigmatize you, and don't want to have anything to do with you. And so you have nobody to reach out to. And we all need help, you know? We all need help.
Help is exactly what Renee Gray needed last fall when she realized that before she could fix her hip, she first needed to get 4 bad teeth pulled. They could pose an infection risk. Renee turned to Phyllis.
She didn't want to go to the dentist. She had a fear of going to the dentist for a long time.
I had to get teeth cut out my gum. That's how bad it was. I was really scared.
Phyllis knew Renee could be at a crossroads moment in her recovery. Pain and discomfort from festering medical issues are a top reason Phyllis sees people relapse. So she made a plan for her and Renee to ride to the dentist together. She assured Renee she'd be right there waiting for her after the appointment was over.
I'm older than her, and I know this, but it's like she was my mother, because I felt safer with her going with me and staying there. I wasn't by myself.
The procedure went off without a hitch. Afterward, the pair caught an Uber to Renee's apartment, Phyllis making sure Renee got inside okay. When we come back, why providers like Reach are so rare, how to improve care for older adults with opioid addiction, and Renee gets ready for surgery. Welcome back. Before the break, we heard how one Baltimore methadone clinic is going the extra mile to improve care for their patients aging with opioid addiction. For the second half of the show, we're going to talk with Tradeoffs senior producer Leslie Walker to put that care into some context. Hey, Leslie.
Hey, Dan.
So look, while I was riding the Amtrak from Philly to Baltimore, you were making calls all around the country, talking with docs, researchers, policy experts, to get a handle on what better care could look like for this group of people. What did you learn?
Yeah, when it comes to care for older adults with opioid addiction, we know Reach is like this kind of unicorn, right? But most of the people I talked to, about 20 folks in total, told me there is some good news. There's actually a lot about Reach's approach that plenty of other places could copy. I'm really talking about three big elements here, Dan. And honestly, these three steps are so universal that if more places took them, a lot of people with addiction could benefit.
That sounds very promising. So what's step one?
Very basic start here, Dan. Get more people on medication to treat their addiction. Specifically, I'm talking here about drugs like methadone and buprenorphine, proven to keep people alive and in recovery. One federal study found that less than 16% of people on Medicare with opioid addiction are getting these meds.
16%, Leslie, that is brutal.
It is. There is a big old mountain of work to do here, Dan. And one priority for older folks, boosting treatment rates in places they're more likely to end up, like hospitals and nursing facilities. Some nursing homes just flat out refuse to admit folks who need medication for addiction.
That sounds illegal?
It is. The Federal Department of Justice has actually taken several nursing home chains to task over this very issue.
I'm a little confused. Like, what's getting in the way of nursing homes? What's making it so hard for them to do this?
Yeah, it's thorny for sure. We could do and we should do a whole separate episode about it. But the bottom line, these facilities argue they need more training, more staffing, and higher pay to get these patients the medications and the care they need. All that said, there is some progress here. One big thing, Medicare finally started covering methadone a few years back, and now 8 out of 10 methadone clinics accept that coverage.
Okay, it sounds like treatment is becoming more available, but as you say, slowly. So that's step one. Step two?
Number two, build trust with patients. Like Renee Gray explained in the first half of our show, right? If your doctor makes you feel bad, no matter what they're offering, you're less likely to go see them.
Right. This issue of stigma or bias seems to run real deep, especially for older patients who have sometimes been mistreated for decades. I saw some of this play out in Baltimore.
Exactly. And Dan, I think that's why in the conversations I heard about people tackling this problem from like all kinds of angles. I heard about medical schools changing how they train future doctors to try to build more empathy, reduce some of this bias. Clinics adding staff like Phyllis, Lindsay, who have lived experience and better understand what folks are going through.
I noticed this is top of mind for Reach too. One thing that stuck with me was that their executive director, Vickie Walters, called their open door policy that folks can relapse as many times as it takes and still come back for treatment. That's the polar opposite of this one clinic where she used to work.
There was a rule that you had 3 strikes and you're out, so you could only come to treatment 3 times. It was an arbitrary rule that was created by a system that really looked at treatment like punishment almost.
Vickie pointed out that many of Reach's older patients, Leslie, have been subject to this really kind of punitive paternalistic system for years. So Vickie's always trying to find like little ways to build up trust wherever she can. She gives staff this stack of McDonald's gift cards that they hand out sometimes.
It's only $5, but you can get a cup of coffee and an Egg McMuffin in the morning for $5. People say to me, other program directors say to me, well, don't they just leave with the gift card? No. They leave, they go get their food, and they come back. They don't even sit at McDonald's and eat it. They bring it back here and sit in the waiting room.
Now, all those little things Vickie's doing for sure add up, right? There's no doubt about it. But experts told me, Dan, that we also need some larger policy reforms to fix this culture of mistrust. For example, historically, people have had to go in person nearly every day to pick up their dose of methadone. The Biden administration loosened those rules, but early data suggests that methadone clinics have really dragged their feet in adopting that new flexibility.
All right, so we've got increasing access, building trust. Leslie, final step.
More coordinating, navigating, whatever you want to call it, Dan. In fact, I think you called it air traffic controlling at the top of our show, right?
I did. I thought that was descriptive.
It was. So this type of work here is especially important for the subset of older Americans who have lower incomes, higher needs, challenges like housing, hunger, lack of transportation.
On top of all of the medical challenges that come with aging.
Exactly. And that all is a whole bunch of stuff, right, that almost no doctor in America has time to deal with. The good news is there is this growing body of evidence that adding these extra team members, they go by many names, case managers, care coordinators, community health workers,
air traffic controllers.
Yes. The evidence is growing that air traffic control work can improve people's health, get them into recovery, and in some cases even save money. That has got more primary care clinics and hospitals providing these sorts of services. And importantly, it's got more health insurers willing to pay for them.
All right, so your 3 steps: access, trust, coordination. There's something you just touched on there at the very end that I assumed would have been one of the 3 steps. It starts with the letter M and rhymes with honey.
Yes. Good old money, Dan. You're absolutely right here. I mean, more money would make all these steps, all this progress go further, faster. I mean, if you want busy providers to counsel patients on their treatment options or connect them to a housing shelter, you got to pay them enough to do those things. The folks I spoke to were totally clear that this work is, woefully underfunded across the board.
Just for a second, Leslie, let's assume that money came pouring in, right? And overnight, care in a whole lot more places looked like what's happening at Reach. What would our return on investment look like? In terms of money, in terms of improved health for people, would it change?
So there is clear evidence, right, that getting more people on medication to treat their addiction saves lives and money. And we just said there's also pretty good evidence for the air traffic control work too. What's less clear is exactly how all of these pieces should work together, right? How many air traffic controllers do you need? Where should home base be for these patients? A methadone clinic, a primary care office, somewhere else?
Key questions to answer if you want to see this sort of work scale, especially on a tight budget.
Exactly. But, evidence in this field is tricky. I was talking with University of Pennsylvania researcher Maggie Lowenstein, who's also a doctor working at a program pretty similar to Reach. She told me a lot of this work is what she called bespoke, right? Each clinic, each hospital putting these pieces together a bit differently. And that can make studies of this stuff hard to generalize.
Right. Plus, I got to think the opioid crisis constantly evolving, the drug supply itself changing, it makes researching this hard too.
Totally. But still, Maggie thinks programs like Reach are on the right track.
If we address people's medical needs through primary care, if we give them medications for their opioid use disorder, and if we address their social needs, their outcomes are going to improve. And those are things that we know work, whatever the drug supply is, and things that we really need to put into practice urgently to save lives.
Look, Dan, there's a lot we still don't know about older adults with addiction. That's something I learned in reporting this story. I mean, this is a deeply understudied population that's growing, changing. At the same time, I mean, the overdose death rate for seniors quadrupled in the past 2 decades. And in my mind, that's clear enough data that we've got to do something differently here.
Leslie Walker, thank you for your work on this story.
Thank you, Dan.
As for Renee Gray, she's now been a patient at Reach for almost 2.5 years. She's accomplished a lot in that time. 14 months off of heroin, blood pressure doing better, smoking habit nearly kicked, finally moved into an apartment all her own. Renee's partner in much of this progress, peer specialist Phyllis Lindsay, says she has witnessed Renee undergo a metamorphosis.
Since I've been here, I've seen a major change in her and, in her behaviors, in her attitudes, and her thinking process, her mindset.
One other major change, the bridges that Renee has rebuilt.
My son told me now that, Mommy, I am so proud of you that you didn't stop doing that drugs and then got yourself together. And, you trying to make the rest of your life a lot better.
When we last spoke, Renee was still waiting for her surgery date. Phyllis has offered to be by her side like she was at the dentist. But this time around, Renee says she has her own people to call on. Her son has volunteered to take her in, her daughter ready to care for her when she gets home.
That's what really make me just say, girl, go ahead and get this thing done. I got so much support. That's what make me just keep going ahead.
I'm Dan Gorenstein. This is Tradeoffs. The federal government has rapidly and strikingly revised recommendations for children's vaccines. Half of states have rejected that new guidance, saying they no longer trust federal information.
We can no longer rely on them to make decisions and public health recommendations based on the best available science.
Next time on Tradeoffs, why this widening rift over vaccines is unlike anything in recent memory and what it all means for our public health.
Thanks for listening to Tradeoffs. If you've just discovered us, remember to subscribe to the feed so you never miss an episode. Subscribing is free and easy on whichever podcasting app you use, the NPR app, Apple Podcasts, Spotify, wherever you listen to podcasts. The Tradeoffs team is producers Melanie Evans and Julie Wernow, senior producer Leslie Walker, managing editor Ryan Levy, managing director of partnerships and growth Eleanor Coetzee, marketing director Catherine Dougal, sound designer Andrew Perella, chief operations officer Colleen Scheck, with help from Kate Seepy, Cedric Wilson, and Haley Lerner. The executive editor is Dan Gorenstein. The Tradeoffs theme song was composed by Ty Sitterman, with additional music this episode from Blue Dot Sessions and Epidemic Sound. Tradeoffs reporting for this story was supported in part by the Foundation for Opioid Response Efforts. Special thanks this week to Casey Bernard, Megan Burish, Edwin Chapman, Peter Donato, Patience Dow, Natalie Ernikoff, Christine Herman, Doug Jacobs, Tammy Mark, Marianne Mason, Ashley Ritter, Lindsay Schwartz, Brad Stein, David Taubin, and Natalie Vasquez. Thanks also to all our listeners who helped to support our work, including Kristen Landrum, David Spohr, Bradley Parsons, Heather Bednarek, Mark Curtis, and Stephanie Streit. Our media partner is Side Effects Public Media, based at WFYI. Tradeoffs is supported by the Robert Wood Johnson Foundation, Arnold Ventures, the Gordon and Betty Moore Foundation, the Sozoze Foundation, Just Trust, West Health, the California Healthcare Foundation, the Foundation for Opioid Response Efforts, and the Leonard Davis Institute at the University of Pennsylvania. Our financial supporters are not involved in any decisions about our journalism. The views expressed in this episode are those of the individuals and not those of Tradeoffs staff, advisors, or funders.